Amenorrhea. The initiation of menstruation is an important milestone in the reproductive lives of women. Amenorrhea denotes the absence of menstruation. It can be physiological or pathological. Onset may be primary or secondary. Physiological amenorrhea naturally prevails before the onset of puberty, during pregnancy, lactation, and after menopause. Pathological amenorrhea is a result of genetic factors, systemic diseases, endocrinopathy, disturbance of the hypothalamic pituitary ovarian uterine axis, gynatresia, nutritional factors, drug usage, psychological factors, and other rare causes. Primary amenorrhea refers to the failure of onset of menstruation beyond the age of 16 years, regardless of the development of secondary sexual characteristics. Secondary amenorrhea refers to the failure of occurrence of menstruation for 6 months or longer in women who have previously menstruated. Normally, the menarche occurs between 10 to 16 years of age with mean age of 12.5 years. Primary amenorrhea at the age of 14 years behoves the clinician to undertake investigation for the cause of failure of occurrence and institute a timely therapy. However, presence of well-developed sexual characteristics, investigation may be delayed until the age of 16 years with the hope that the spontaneous menstruation will eventually ensue in due course of time. This occurs in delayed puberty. Classification. It is classified according to the status of her serum FSH levels into hypergonadotropic if the levels are greater than 40 milli-international unit per ml, eugonadotropic or hypogonadotropic. Causes of hypergonadotropic primary amenorrhea are gonadal dysgenesis, 45XO Turner syndrome, mosaics, abnormal X chromosome, 46XX pure gonadal dysgenesis, 46XY gonadal dysgenesis like Swyer syndrome, testicular feminizing syndrome, gonadotropin resistant ovary syndrome or Savard syndrome. Causes of eugonadotropic primary amenorrhea are absence of Mullerian development as in androgen insensitivity syndrome, Mullerian agenesis, the absence of vagina or uterus as in Rokitansky-Kushner-Hauser syndrome. Normal Mullerian development in female or true intersex, PCOD, adrenal or thyroid diseases. Cryptomenorrhea due to imperforate hymen, vaginal septum or cervical atresia where the menstruation occurs but bleeding does not occur. Tubercular endometritis, constitutional delay as in nutrition deficiency. Hypogonadotropic primary amenorrhea. Hypothalamic causes like delayed menarche and puberty. Hypothalamic hypogonadism, Kallmann syndrome, gonadotropin releasing hormone deficiency syndrome, psychogenic causes, weight loss, stress, anorexia nervosa and malnutrition. Pituitary causes like pituitarism, short stature, obesity, genital dystrophy, mental retardation, polydactyly, retinitis pigmentosa. Neoplasms like prolactinoma, craniopharyngioma, adenoma, empty cellular tarsica. Hypopituitary states like Simon's disease, Chiari-Frommel syndrome, Forbes-Albright syndrome, pineal gland tumor. Or in severe systemic diseases like tuberculosis, syphilis, other endocrinal disorders like thyroid, adrenal gland deficiencies. Etiology. According to the location of the cause of amenorrhea, etiology is as follows. It may be delayed puberty. Pregnancy before menarche is extremely rare but not impossible. Cerebral cortex disorders, stress, emotional disturbances, infection, trauma, tumor. Hypothalamus causes Kallmann syndrome, vigorous exercise, weight loss. Pituitary gland, empty cellular syndrome, Froehlich syndrome, Lawrence-Moon-Beadle syndrome, Cushing disease, pineal tumor, prolactinoma, galactosemia, ovary Turner syndrome, primary ovarian failure, Savard syndrome, polycystic ovarian disease, 17-hydroxylase deficiency. Genital tract causes absent uterus, Meyer-Rokitansky-Kushner-Hauser, MRKH syndrome, testicular feminizing syndrome, refractory endometrium, obstruction in the lower genital tract, genital tuberculosis, Asherman syndrome, chromosomal intersex, Turner syndrome, testicular feminizing syndrome, Swyer syndrome. Other endocrine glands, juvenile diabetes, thyroid, adrenal glands. Drugs, tranquilizers, antihypertensive, antidepressant, metoclopramide, estrogen. Nutrition, overweight, weight loss, tuberculosis, malnutrition. Anorexia nervosa is a psychological, somatic, self imposed eating disorder mainly affecting adolescents, young women more than men. It is a failure to maintain body weight for age and height. For menstruation to occur, minimal fat should be 22% of the body weight. Loss of weight greater than 15% causes amenorrhea. Leptin in the fat initiates GnRH secretion. When weight reduction falls below the required body fat, GnRH and gonadotropin secretions fail. Clinically, fasting, excessive exercise with or without purging, self induced vomiting can cause atrophy and non development of breasts and amenorrhea. Hypoestrogenism thus induced following causes: mortality through heart failure, arrhythmia in 15% cases, amenorrhea, infertility, decreased libido, osteoporosis. Hypercortisolism, decreased muscle mass, low IGF-1, hypothyroidism, anemia, granulocytopenia, neutropenia, psychiatric problems. Management includes psychological and psychotherapy. Nutritional support, GnRH to initiate HPO axis, hormonal therapy to initiate or complete the HPO axis. Kallmann disease, it occurs in 1 to 50,000 girls. Low or absent GnRH is due to autosomal dominant or an X-linked autosomal recessive gene. This condition is characterized by anosmia and maldevelopment of neurons in arcuate nucleus. GnRH and pituitary hormones to induce menstruation, ovulation. Estrogen, progestogen cyclically to induce menstruation. Clinical approach. The clinician is required to make an assessment of the cause of primary amenorrhea on the basis of history, clinical examination, and tests that are most likely to provide answers to the underlying cause. History of diabetes, TB, mumps, family history of PCOD, delayed puberty, testicular feminizing syndrome, height, weight, breast development, thyroid enlargement should all be noted. Abdominal mass should be looked for. Ultrasound for presence of uterus, hematometra, presence of ovaries. Chromosomal study must be done. Clinical features of Turner syndrome are short stature, low hairline, shield-shaped thorax, widely spaced nipples, shortened fourth metacarpal, small fingernails, brown spots or nevi. There is no menstruation, rudimentary ovaries or streaked gonads, elbow deformity, poor breast development, coarctation of aorta, characteristic facial features. Approach to primary amenorrhea. Look for the breasts and uterus. If breasts are absent but uterus is present, then it indicates lack of estrogen production from the gonads, HPO failure, lack of ovarian follicles, or 2 active X chromosome, or Turner syndrome, or presence of uterus indicates that the Y chromosome is absent. FSH level identifies the cause of lack of estrogen. High FSH indicates ovarian failure. Low FSH indicates hypothalamic pituitary failure. GnRH distinguishes hypothalamus cause from a pituitary cause. If breasts are present but uterus is absent, then it indicates the presence of gonadal estrogen but Mullerian agenesis, or presence of Y chromosome or testicular feminizing syndrome. Serum testosterone levels are high in androgen insensitivity syndrome but normal in 46XX with Mullerian agenesis. Karyotyping confirms the genetic sex. Gonadectomy is advised for androgen sensitivity syndrome and Mullerian syndrome. If breasts are absent but the uterus is present, it indicates lack of estrogen because of the gonadal agenesis, absence of gonads, or gonadal enzyme defect. Absent uterus indicates the presence of Y chromosome with testis that suppresses the Mullerian development. Presence of normal female external genitalia indicates the absence of testis. Hence, no testosterone present when the external genitalia were developing. Karyotyping 46XY, high FSH and testosterone. Normal female range suggests gonadal agenesis absence. Gonadal biopsy to detect the enzyme deficiency. If both the uterus and breasts are present, it indicates estrogen is present, uterus is present, indicates Y chromosome is absent. Investigations must be done are progesterone challenge test, serum prolactin and thyroid profile, tests to exclude the genital TB, urine test for presence of beta HCG and UPT, and ultrasound to rule out pregnancy. Here uterus is absent. Management. For hypergonadotropic primary amenorrhea, patients have gonadal failure. In them, the FSH levels are greater than 40 milli-international units per ml and low estradiol levels less than 25 picogram per ml. Sexual development is prepubertal with no endometrial proliferation. Hence, the progesterone challenge test is negative. Chromosome study revealed 45XO chromosome or Turner syndrome. Some patients with mosaicism or minor structural abnormalities of the X chromosome may have few functional follicles capable of inducing menstruation, stray ovulation, and pregnancy. Chromosomal study is relevant. Gonadectomy is indicated in patients with testicular feminizing syndrome as the male gonads are prone to malignancy. Women with streak ovaries are infertile but they can bear children with oocyte donation. All women in this group must be treated with cyclical estrogen and progesterone to promote feminization and secondary sexual characteristics and prevent osteoporosis. Women with resistant ovarian syndrome have normal ovaries on histology. They show the presence of primordial follicles, but there is probably a deficiency of receptors for FSH. They are not amenable to treatment. Savant syndrome is due to receptor defect of gonadotropic hormone in the ovaries and resemble autoimmune disease and resistant ovary syndrome. The height is normal, ovaries contain follicle, but serum FSH is raised. In eugonadotropic primary amenorrhea, if the SHS levels are normal range, the women have normal breast development, but due to abnormal Mullerian development, uterus may be rudimentary or absent due to insensitivity to androgen. In women with testicular feminizing syndrome, the phenotype is female with karyotype of 46XY. Gonads are testes, often present in the inguinal canal and produce testosterone and Mullerian inhibiting factor, but because of androgen insensitivity at the target organs due to deficient androgen receptor or lack of enzymes to convert testosterone to the more active dihydrotestosterone, these patients present with lack of axillary hair, pubic hair, absent uterus and upper vagina. They have a blind pouch of the lower vagina. Breast development appears normal because of the peripheral conversion of androgen to estrogen. These gonads are prone to malignancy. Therefore, as soon as the full sexual development is achieved by the age of 18 to 20 years, a prophylactic gonadectomy should be advised, followed by estrogen therapy to maintain feminization. Vaginoplasty may be contemplated at appropriate time in the future. On contrary, women with simple Mullerian agenesis and a karyotype of 46XX present with normal secondary sexual character and functional ovaries, they reveal normal hormone profile. This syndrome is associated with renal and skeletal abnormality in 30% of cases. These women do ovulate. Appropriate management requires creation of functional vagina for coital purpose. If they plan to have children, it may be through surrogacy. In women with cryptomenorrhea presenting as primary amenorrhea, the common cause is an intact hymen or vaginal septum. A history of cyclic abdominal colicky pain, retention of urine, presence of palpable abdominal lump, and visualization of tense bluish bulging membranes on separation of labia enables the diagnosis. Ultrasound scan of the pelvis confirms it. A simple cruciate incision of the hymen permits free drainage of the collected menstrual blood and leads to normal reproductive function. Septate vagina or atresia vagina requires excision and vaginoplasty. The vaginal septum is recognized from the imperforate hymen by a pinkish concave covering in contrast to the bluish convex bulge in the latter. The vaginal septum or atresia requires more extensive dissection and vaginoplasty. Atresia in the upper vagina and cervix often restenosis after surgery and eventually requires hysterectomy. Polycystic disease is described later. 17-hydroxylase deficiency causes deficit cortisol secretion, raised levels of adrenocorticotropic hormone. This causes hypertension, hypernatremia, hypokalemia, and amenorrhea. Endometrial non-responsiveness and amenorrhea are due to absent hormone receptor. Hormonal profile remains normal. Tubercular endometritis requires anti-TB treatment. In hypogonadotropic primary amenorrhea, FSH levels are less than 40 milli-international unit per ml. It is usually a result of hypothalamic dysfunction, pituitary failure, or systemic illness. Administration of GnRH helps to differentiate hypothalamic dysfunction from pituitary failure. In pituitary failure, GnRH stimulation will not raise the luteinizing hormone level. Empty cellular tarsica is characterized by herniation of subarachnoid membrane into the pituitary cellular tarsica and may exist with pineal gland tumor as prolactin adenoma. The absence of pituitary gland causes the absence or low level of FSH and LH. Gonadotropin hormone therapy is required. Other hormonal dysfunction. Both hypothyroidism and hyperthyroidism can cause amenorrhea. Congenital adrenal hyperplasia and tumor are also responsible for primary amenorrhea. So does juvenile diabetes. Premature ovarian failure is seen in 1% of the cases due to poor germ cell migration from the yolk sac during fetal development or due to accelerated rate of depletion of unknown reason. FSH level is more than 40 ml international per ml. E2 level is below 20 picogram per ml. Karyotyping is required. The woman presents menopausal symptoms. She needs hormone replacement therapy. Nutrition. Excessive weight, anorexia nervosa, malnutrition with loss of weight are all responsible for amenorrhea in young girls. The most common cause of hypothalamic dysfunction is related to psychogenic effects, anorexia nervosa, weight loss, and inappropriate secretion of neurotransmitters leading to lack of GnRH synthesis, as in Kallmann syndrome. Women with Kallmann syndrome manifest isolated deficiency of GnRH associated with olfactory dysfunction and anosmia. Pituitary failure generally follows hypopituitarism, neoplasm, empty cellular tarsica, skull radiography, preferably MRI, estimation of prolactin levels, ophthalmic evaluation for the field of vision helps to arrive at the diagnosis. Froelich syndrome consists of short stature, lethargy, obesity, genital dystrophy, and amenorrhea. In Lawrence-Moon-Biddle syndrome, polydactyly, retinitis pigmentosa, and mental deficiency are the additional features. In all such women, cyclical administration of estrogen, progestogen to maintain femininity, prevent osteoporosis is essential. In the case women desire to conceive, induction of ovulation with gonadotropins is warranted. Women with neoplasms, appropriate neurological consultation followed by treatment with bromocriptine for prolactinoma or surgery should be planned. Approach to primary amenorrhea. Absence of menses by 14 years of age with normal pubertal changes. Examination of girl, height, weight, breast, pubic and axillary hair is done. In case of normal height, weight and breast development, look for the presence of vagina. If the uterus is absent, non-canalized vagina, then it is Mullerian agenesis. If the uterus is present and vagina is patent, look for Asherman syndrome or ovarian dysgenesis. Raised FSH-LH levels are present in ovarian dysgenesis. If there is short height, poor breast development, then it is suggestive of Turner syndrome. If it's tall or normal height with features of hirsutism, look for signs of androgen insensitivity or polycystic ovaries.